Hello, everyone. We are about 5 minutes away from going live. Come on in when you are ready. We are here for an Archer free webinar. I'm Morgan, and I'm so excited to be with you guys tonight. If you want, go ahead and drop down in the comments where you are joining from. And we are getting started in just 5 minutes. Today's free webinar is a little taster for you on congenital heart defects. We are going to be talking all things congenital heart defects, one of my favorite topics. So, welcome in. Again, about 5 minutes till we start today's webinar. Welcome in, love from Nigeria. So happy to have you here. For those of you just hopping on, go ahead and let us know down in the comments where you are joining the Archer free webinar from today. We are so excited that you are here. Again, my name is Morgan. I'm going to be walking you through a short little highlight reel on congenital heart defects. We've got Vanessa from Houston, Jaslyn from Canada. Welcome. Malaya from Virginia, Allison from Georgia, Gina, it's lovely to have you here. Thanks for hopping in. Vivian from Texas. Gina is here from Chicago. We've got Elsa joining from China. P. Shar from Calgary. A couple of our friends from Canada. Lovely. And we've got some friends from Texas. That is where Archer Review is based. Our headquarters are in Austin, Texas. I myself this evening are broadcasting from North Carolina. So North Carolina is where I'm at today. It is very hot and humid. I am a little bit over the heat. I'm ready to go back to spring instead of these East Coast summers. All right, we've got Christine from Austin right around the corner from our office. Love to see you here. Thanks, Christine. Welcome. Bernadette joining on YouTube over from California. Callie from Orlando. I just flew in this morning from Tampa. Had a little conference down in Tampa over the weekend. So great to see our Florida friends here. Lindsay from Chicago, Agnes from Virginia. We've got some of our friends from India over joining us on Instagram. Love to see that. You guys are up studying late. It is late over there for you. So for those of you guys who don't know, we at Archer do a free webinar on Mondays, Wednesdays, and Friday, and we broadcast them everywhere from Instagram and TikTok to Facebook and YouTube so that we can hopefully reach as many of you as possible. I know you guys are busy, you're studying on the go. Hopefully, you can get just a little like bite-sized nugget that you can take with you wherever you are at. We're going to get started in just 2 minutes here. Today's little bite-sized free webinar is on my favorite topic in the world, congenital heart defects. I did not get a lot of info on congenital heart defects in nursing school, and I definitely had NCLEX questions on it. I did not feel super prepared. I later went on and worked in a pediatric cardiac ICU, and I kind of fell in love with the heart defects. They're complicated, but they're this puzzle that when you put the pieces together, everything really makes sense, from the signs and symptoms that the kiddos have to the treatment, the surgery, the way we address them. So I ended up really liking them, thinking they were really cool, and therefore they are one of my favorite things to teach. So I am going to close this out for us, get our volume off, and go ahead and just say one more time for those of you joining us in here, we're getting started in 1 minute. If you haven't let us know where you're joining from, now is your chance. We've got Jennifer joining in from LA, Mackenzie from Hawaii. Welcome, Mackenzie. I spent a year living in Oahu. It was one of my favorite years of my life. The North Shore of Oahu has a very special place in my heart. And another Hawaii, Fabian from Hawaii. Welcome, everyone. Cheryl from Pennsylvania, Emma from New York. We've got some of our Instagram users on Ohio, Joanne from Qatar, Dela from Sacramento. We really have friends joining truly from all over the world today. Australia to Nepal to New York, Alabama, Illinois. There is a little bit of everything. And I hope I can leave each and every one of you with a few little takeaways just so that you get a taste for how amazing congenital heart defects can be. And ultimately, let's be honest, why we're really here, so that hopefully you guys feel better about these questions on your NCLEX, okay? Tonight is going to be a taste. Again, I know y'all are on the go. You're streaming, you're on TikTok, you're on Instagram. We're going to hit the highlights and give you some really nice key takeaways. If you like what you see tonight and you want to dig deeper with me, if you want to join me for a full hour where we demystify all of the congenital heart defects, I will be offering that 2 weeks from today at noon Central Time on July 14th. The cost for that 1 hour webinar where we totally bust out all the congenital heart defects is going to be $25. $25 for 1 hour. We have the QR code and the link up here. You can go to archerreview.link/peds and you will be able to join that full 1 hour webinar. Again, tonight we're going to start off with a taste. We're going to get you some key takeaways so that hopefully you guys know what you're getting into and you can walk away feeling a little more confident. Okay. The first key takeaway I want you guys to get: we have different circulation in utero when we are a baby living off of mom than we do when we enter the world and we take our first breath of air. So fetal circulation specifically skips our lungs. We do not send blood to our lungs when we are still in utero. That sounds completely bananas, but like when you think about it, you're in utero, you're in amniotic fluid, you're floating around, you're getting all your oxygen from mom. You do not need to be expanding your lungs. You shouldn't be because you're in amniotic fluid. You're swimming, right? You're a little fish. Okay, so we don't want to get the blood to the lungs. Therefore, we have to have a way to skip it. And that comes in the form of 2 holes. Yes, holes, openings in the hearts. The first is the foramen ovale. The second is the ductus arteriosus, okay? Let's start with the foramen ovale. It's a hole between your right and left atrium. Okay, so right up at the top of your heart, those top 2 chambers, your atria, we're going to have a hole there so that when blood goes into the right side of the heart, it doesn't necessarily have to then go into the pulmonary artery and out to the lungs. It can just skip over the left side by going through that hole. You guys see that right there? That's the foramen ovale. Second hole is the ductus arteriosus. So some of that blood coming in the right side right there still ends up going through the pulmonary artery. We don't really want it to go to the lungs, so it can go through this hole between the pulmonary artery and the aorta. Hole between the pulmonary artery and the aorta, that is the ductus arteriosus. And that lets us send that deoxygenated blood from the right side out to the body instead of going to the lungs where we don't need it to go. All right. So these 2 holes, foramen ovale, ductus arteriosus, they should close once we're inhaling and we're opening up our lungs. But while we're in utero, we don't need them to. So tell me, quick knowledge check, put it in the comments wherever you're tuning in from. Tell me what the foramen ovale allows. Why do we have this hole? Where is it? What is it allowing? Right? Our bodies are really cool. We wouldn't just have a hole in our heart forming in every baby's heart if we didn't actually need it. So tell me what the foramen ovale allows. It's going to allow blood to move through the hole where? Stephanie hit the nail on the head. It allows blood to bypass pulmonary circulation. Nice job, Malaya. It allows blood to go from the heart to the body because we don't really want it to go to the lungs. Let's skip the lungs. Bypass the lungs, skip those lungs. And remember, the foramen ovale is between the right and left atria. It's a hole between the atria. Okay, amazing. That allows you guys to move on to concept number 2. When blood moves through a hole, it is called shunting. All right? And blood shunts in one direction, high to low pressure. Blood is lazy. It's never running uphill if it doesn't have to. It's like me. If I can take the elevator down, there is no way I'm walking up the stairs if I don't have to. Blood's the same way. We are going to go high to low pressure. Now, which side of the heart has more pressure? The left side. The left side is bigger. It is bulkier. It has more muscle because it sends blood out to the body. Like it just, it's got more pump. So the left side will be higher. Therefore, under normal circumstances, blood is going to move left to right if we've got a hole going on there. Now, think about what side of the heart has oxygen and what doesn't. We know on the right side of our heart, it is deoxygenated blood that is returning from the body. On the left side of the heart is where we have the oxygenated blood returning from the lungs. So if I have shunting from left to right, I have oxygenated blood moving from my left to my right. It means I get a little extra blood going out to my heart. We call that pulmonary overcirculation, and it can make my lungs a little wet. But is my baby going to turn blue? Nope, negative. I'm getting good red oxygenated blood. I'm just getting extra to my lungs. This is an acyanotic heart defect. When we break up heart defects, the two big buckets are, does the baby turn blue or do they not? If the baby turns blue, it's cyanotic. If they don't, A means without cyanosis, acyanotic. And that happens with a left to right shunt because we got oxygenated blood from the left, high to low pressure across the hole over to the right side. Bada boom, bada bang. Thumbs up. Does that make sense? Does a left to right shunt leading to an acyanotic heart defect make sense? Give me a thumbs up, a heart, a comment, or a thumbs down. Do I need to say it again? What do you guys think? Left to right shunt, oxygenated blood from high to low pressure, acyanotic heart defects. All right, Malaya's got it. Yes, I've got a okay signal. What do we think? Elizabeth, Clinton, Petros. What do we think? We've got it. Allison says yes. Christine. Okay. So what's the other option? My other bucket is that my baby does turn blue. I am, in fact, cyanotic. Okay. Whew, how does that happen? Well, blood moves the other way. We have blood on the right side that is deoxygenated. It's coming back from the body. It's already dropped all its oxygen off, so it's blue. It's out. It's fresh out of oxygen. It's coming back to the right side of the heart, and something has happened to make the pressure in the right side go up. So it's moving from right to left. Now I'm getting deoxygenated blood over to my left ventricle. And where does the left ventricle send blood? Out to the body. So I start getting deoxygenated blood right to left, out to my body. I turn blue. I'm cyanotic. All right. Capiche? Do we understand shunting? We see the holes in the heart. We see the direction blood moves. That's called shunting. And we understand that that shunting leads to it being either cyanotic or acyanotic. Okay? Boom, you guys, you've got the first concept down. Now we're just going to take all that and we're going to look at where different holes can be, what different things can form incorrectly, and we're going to put that all together into our big heart defects, okay? So these are the buckets. Acyanotic, we've got a PDA, we've got an ASD, a VSD, and then we put those together, we get an AV canal. For cyanotic, we've got things like TGA, tetralogy of Fallot, tricuspid atresia, hypoplastic left heart syndrome. These are where the babies turn blue. Are we going to go over every single one of these defects today? No. I know you guys are scrolling. You're watching something really quick. That is okay. Remember, that is what our full 1 hour dedicated webinar is for. If you want to go over every single one of those heart defects and really apply the holes, the shunting, the cyanosis to every heart defect, sign up for our 1 hour congenital heart defects demystified. This is going to be with me, 2 weeks from today on July 14th. It is from 12 to 1 p.m. Central Time. If you can't join live, you will get the recording. It's going to be $25 for that 1 hour. And you can scan that QR code or go to that archerreview.link/peds and go ahead and save your spot in this class. So again, we're going to hit the highlights tonight. We're going to give you a little teaser, a little taste. And if you want to dig deeper with me, go ahead and save your spot there. But you guys already got the first major takeaway. You looked at the holes in the heart. We've got that foramen ovale between the right and left atria. We've got that ductus arteriosus between the pulmonary artery and the aorta. Those are letting the blood skip pulmonary circulation. They're skipping the lungs while we're still in utero. When we've got those holes, though, blood moves across the holes. And when blood moves across a hole, it is called shunting. Blood's lazy. It goes from high to low pressure, which in a normal heart, the left side is higher pressure. So we go left to right. We get oxygenated blood on the left over to the right. Sends a little extra juice into the lungs, makes them a little wet, but it doesn't turn our baby blue. Not blue without cyanosis. That is acyanotic. And that is the first major group of heart defects that we are going to look at. Starting out with one of the most simple, but most common, a PDA, a patent ductus arteriosus. And you guys already know what a ductus arteriosus is. It's the hole between the pulmonary artery and the aorta. What does patent mean? Does anybody remember? Put it in your chat, put it in your comments. Tell me, what does it mean if something is patent or patent? People say it different ways, tomato, tomato. If something is patent, it is open. Thank you, Rebecca, Allison, Evelina. Patent means open. We want a patent airway. We want our fistula to be patent for dialysis. But we do not want our ductus arteriosus to be patent because we need it to close so we can get blood to the lungs now that they're working for us, now that they're breathing, okay? If this hole doesn't close in 12 to 72 hours, it is a PDA, a patent ductus arteriosus. Here's what you're going to see on your exams. The type of murmur that you will auscultate in these babies is a machine-like murmur. A machine-like murmur is what you will hear with a PDA. All right, I want you to write that down, make a flashcard, definitely remember that. What do we do about them? Most of the time, if they're small, we just kind of let it fly. We watch. It might take them until they're like 5 or 6 for it to close. Most of them close on their own. If they do not, step 1, we can try medical management. We see this often in the NICU. Indomethacin or ibuprofen, okay? Those are NSAIDs. Don't ask me why, but they help close the PDA. They help close, okay? Now, we're going to tuck this into our back pockets for later. Don't get too confused. We've got one more medication. It's not even on the slide. A medication that keeps the ductus arteriosus open. And that medication is called alprostadil, okay? So 2 things. Please repeat what helps close the PDA. I gotcha. Because I want you to remember these medications. This is a key takeaway. Indomethacin or ibuprofen, you see right there? That helps close the PDA. The medication that opens it is alprostadil. Those are the 2 meds you're going to want to know when it comes to PDA. The other thing, that machine-like murmur. All right, question from Christine. So when the blood returns to the lungs, left to right, does it cause the baby to have fluid overload? Yes, yes, yes. We are going to see that in our next defect ASD and even more in a VSD. Christine, you are so right. When we have that left to right shunt, because we've got some hole and the pressure on the left side is higher, and it ends up sending a lot more fluid to the lungs, it causes some of our symptoms of heart failure, that fluid overload, because we're not being able to push the blood forward, okay? They fatigue easily. They have dyspnea on exertion, bilateral crackles. They don't eat very well because they're trying to catch a breath and they can't, latch and breastfeed or bottle feed. So they are poor at gaining weight. they're often really sweaty because they're just working up a sweat, just trying to exist as they pump blood forward, but they get a lot more to their lungs. So that left to right shunt causing more blood to go to their lungs is what causes a lot of our heart failure signs and symptoms in children with a heart defect. Now, the ASD, where is that? What does that mean? It is an atrial septal defect, ASD. This is when we have a hole between the atria. Again, pressure on the left side is high. It shunts blood left to right. We get a little extra to our lungs. We just talked about that's why it causes our symptoms. We're going to hear a murmur. Again, small ones often close on their own. Big ones, we got to go to surgery. We got to put a little patch to close that hole so the blood doesn't shunt through. All right, that is an ASD. Question here from Callie, is alprostadil the same thing as prostaglandins? Yes, Callie, it is. I should have said that. Alprostadil is the same thing as prostaglandins, is the same thing as PGE. Those are all the same medication. They keep that PDA open. Amazing. So far, these are acyanotic defects. We've got extra blood going to the lungs, causing some heart failure symptoms. PDA, we've got our machine-like murmur. We've got one more to talk about, though. If we can have a hole between the atria, where is one more place that we could maybe have a hole? Between the ventricles, right? Between the ventricles. VSD is a ventricular septal defect. That's right. Good job. Between the ventricles. That's when we have a hole down below. We've got usually a bigger hole because it's kind of a bigger wall between those bigger chambers. So we see a lot of the same things. We see dyspnea on exertion. That's DOE because they're getting a lot of extra fluid to their lungs. We see all those heart failure things, those crackles, those rails. They don't eat very well. They don't gain weight very well because extra blood to the lungs. They have a louder murmur usually because we got a pretty good hole here that blood is whooshing across. And we typically need to do a little more management here. Sometimes we do diuretics to get some extra fluid off, or an ACE inhibitor to reduce their afterload, a beta blocker to make their heart squeeze harder. Those are all things we do for heart failure, right? Because essentially their heart just has this anatomical defect, and it's a lot harder for it to work. So we're going to make it easier for it to work. Now, most kids with a ventricular septal defect, a VSD, they're going to need to go to surgery. We're going to need to put a little patch there to cover up that hole so we stop having shunting, okay? So those are the big acyanotic defects I wanted you guys to get. You've already kind of checked off a lot in this quick little webinar. Acyanotic, blood goes left to right. We get some extra blood in our lungs, but we do not turn blue. First, we have the PDA, that gap, that opening between the pulmonary artery and the aorta. Then we have the atrial septal defect, the ASD, where we've got a hole between the top. And then we have a VSD, where we got a hole between the bottom. Let's recap the two medications we talked about. Which med can be used to keep the PDA open? If we want our ductus arteriosus to remain patent, what is the medication? It wasn't on the slides. We talked about it out loud. Put it down in the chats wherever you are joining from. To keep it open, we talked about two different groups here. To keep it open, Faith's got it. Absolutely. Shannon, you know it. Avreen, it is the alprostadil. Alprostadil is also known as prostaglandins or PGE. Nice job, Mansua, over on Instagram. You've got it absolutely right. Fatu, Cindy, alprostadil. Alprostadil, prostadil. It is going to press that PDA open. Now, Jane asked a great question. Why in the world would we want to keep that ductus arteriosus open? Because usually we want to close it. Well, The answer is if we have a complex congenital heart disorder, which we're not going to get to today. We're going to do that in the full 1 hour paid webinar. But if we have a complex congenital heart defect, like for example, coarctation of the aorta, where that aorta is closed off down here, I might need an escape hatch. I might need a hole right here where some blood from my right can get out to my aorta through the pulmonary artery in order to make it to the rest of my body. And if I need that escape hatch, the baby is called ductal dependent because they are dependent on that ductus arteriosus for systemic blood flow. So if that's the case, we need that alprostadil. I'm going to spell that for you guys. Hold on, I'm typing it out. Alprostadil, prostadil. I'm probably spelling it wrong here. Or prostaglandins. Prostaglandins. There we go. Okay, so I'm typing that out. I'm putting it in the chat so you guys can see it because that was not on our slides. Alprostadil or prostaglandins, that's the medication that keeps the PDA open. Now, some of you put the other medication that we talked about. That medication that closes the ductus arteriosus is the indomethacin or ibuprofen. These are NSAIDs. NSAIDs, indomethacin, ibuprofen, these are going to close the ductus arteriosus. This is a much more common scenario because a lot of times premature infants, maybe they come at, 28 or 29 weeks. They're not fully baked. Their heart didn't quite have time to totally close up what it needed to, and we need to help it out. So very common medication to give in the NICU or in the intensive care nursery where we want to close up that ductus arteriosus. I have mainly used indomethacin. The efficacy, the research is the same. Indomethacin or ibuprofen that closes up that ductus arteriosus. Yes? Makes sense? Do we understand the difference between the indomethacin and the alprostadil? Christine's got it. Yes, absolutely. I love it. I love it. Now, question here in our question box in Zoom. Are we getting a link to be able to access these notes? Not from our free webinar here today. This is just a quick little taste, hitting the highlights, hopefully giving you guys some nuggets to take back to your NCLEX. If you would like an expanded presentation where we break down all the congenital heart defects, we demystify the whole shebang, and you get the entire handout. Sign up for Congenital Heart Defects Demystified with me. This is in 2 weeks on July 14th from 12 to 1 p.m. Central. It is going to be $25 for the 1 hour session. It will be recorded, so you can go ahead and get that recording, rewatch, or if you can't join live, you can see that recording. Scan the QR code or go to that archerreview.link/peds and you will get that 1 hour session. All right. So hopefully that answered that. Answering another question here in the chat. If you guys have anything else, go ahead and pop them in there. I have one more point to go through, and then any questions you have, I'm going to make sure to answer on the spot. So you can go ahead and put any questions that you want down there. But you guys, you already got a lot of good nuggets here. We already went through those different holes of the heart. We'll recap here at the end. Your first hole, that foramen ovale between the atria. Your second one, the ductus arteriosus between the pulmonary artery and the aorta. And you understood that when blood moves across one of those holes, it is called shunting. Normally, we have more pressure in our left side, so we shunt left to right, which is preferred because the left has the oxygenated blood. So it sends a little extra to the lungs, might give us some heart failure symptoms, but it doesn't turn us blue. We are acyanotic without cyanosis, and that is our PDA, ASD, and our VSD. PDA, that ductus arteriosus, it don't close. It remains patent open. ASD, we've got a hole between our atria, atrial septal defect. And VSD, we have our ventricular septal defect. Okay, now what happens if we, for some reason, get more pressure on our right side? Then we're going to shunt right to left. We're going to start getting deoxygenated blood over to the left side. That's going to be going out to the body, and it's going to be causing cyanosis. So if you'd like to break down those more complex heart defects with me, again, join me in 2 weeks on the 14th, and this is what we're going to be going over: TGA, hypoplastic left heart syndrome, tetralogy of Fallot, tricuspid atresia, coarctation, stenosis of the aorta, and pulmonic valve. These are more complex heart defects that can cause that cyanosis. So again, we're going to be doing that in 2 weeks. That is on July 14th from 12 to 1 p.m. I will leave this up so you can scan that or head to that URL to go ahead and sign up. And I am just going to start answering any questions that you guys put in the chat, whether you're on YouTube, Facebook, Zoom, Instagram, TikTok. Feel free to put any and all heart defect, NCLEX, nursing school questions in the chat, and I will just jump in to answering those. So the first question from Christine: how is indomethacin administered with neonates? Okay, we have a couple of options. It can be given IV if they really can't tolerate anything at all into their little bellies. And if they're, like a 25 or 26 weeker, that probably is what it'll be. But we also have feeding tubes. Oftentimes they are either crushed or in an oral suspension that is put into a feeding tube, or if they're eating by mouth, it might be put in their cheek with a little oral suspension while they're sucking on a bottle or breastfeeding. So lots of different ways to give meds to neonates. Those are just some of the options. Obviously, they're not swallowing a pill, so we have to use one of those others. I take my NCLEX this Wednesday. Oh my gosh, 2 days. Nice job, Callie. What should I do tomorrow to prepare? Okay, so Callie, do you have an Archer Review account? I should have already been signed into mine. Hold on. I am going to show you exactly the resource for the day before your exam. Okay. Let me move my little face here so I can see the account. So I want to make sure you guys know where this is. We have a study guide that basically walks you through exactly what to do the week of your NCLEX. And it's got a guide for what to do the day before. So I am going to pull that up. Make sure you know where it is, Callie, because that will do you a lot more good than me just talking at you. You'll actually be able to see it. Okay, here we go. So changing this share over for you, Callie. Let me know when you can see that Archer Review account screen. So that is where, once you have an Archer Review account, this is kind of like your home page, right? You've got your little dashboard over here. You've got different things. So I want you to come down to study calendar and click on week of exam study guide. Okay. The week of exam study guide, you've got a little table of contents. It walks you through the major things that I want you to briefly review. And then it tells you what to do the day before your exam. So again, that is in your Archer dashboard under study calendar, week of exam study guide. So that is really, really what I want you to do at a high level for any of you who are testing really soon. The day before, you should mostly be just reviewing those high yield concepts and resting. All right. You shouldn't be doing a bunch of practice questions. You should not be taking readiness exams or CAT assessments. That's not necessarily going to help you at this point. Your brain knows what it knows. You're going to review those high yield sticky concepts, and then you're going to fuel up your brain for test day. So Callie tests on Wednesday. So on Tuesday, Callie, I want you to do some of that week of exam study guide, review those high points. I want you to put things away by lunchtime. I want you to go on a walk, eat a good lunch and dinner, high in protein. I want you to go to sleep at a good hour. All of those things that are going to get your brain into like its best space, okay? Because you know what you know, right? You're not going to like magically absorb a bunch more information the day before. But what you can do to dramatically increase your chances of passing is get your brain ready to be in its best shape on point. Okay. So that is that. All right. I have mine on the 11th. So on the 10th, I relax, get a massage, and sleep early. I love that. That is an amazing plan. Absolutely fantastic. Just review just right, no more questions. I love to hear that. That is perfect. And we've got a bunch of people testing this week on the 9th, on the 10th, on the 11th. You guys, please come back and let us know once you have passed. It really is the most rewarding part of this job. I mean, I'm a nurse just like you guys. I've spent my career in pediatrics, ended up going back to school to be a pediatric nurse practitioner. But along the way, I was like, nurses are struggling. All of the nurses that I'm precepting, everybody that I'm working with, we do not have the support systems we need. So I'm here to build that support system. Archer is that support from the day you decide you want to go to nursing school through the rest of your career. So whether it's passing the NCLEX, succeeding in your fundamentals course, going back to school, I want to be your partner in crime. I want to do this with you. Please keep in touch. Let us know how it is going. And I promise we are there with you every step of the way. Question 4, if we provide private tutoring. We sure do. Archerreview.com at the very top, you'll be able to click on nursing and then you will see private tutoring. We have both 30-minute and 60-minute sessions, so you can kind of figure out the timing, what works for you. My personal favorite, I love just doing like a 30-minute intro session so that you can talk about what your needs are. You can kind of let me know, like, this is what I'm struggling with, this is when I'm testing, and then we can make a plan from there, depending on exactly what your needs are. Okay. Let's see. Really good question here. How do we come back without a subscription? Yeah, you don't need to subscribe to enjoy Archer Review. We put a lot out there for free. So, Michelle, you can join us live on Instagram, TikTok, Facebook. Which one did I miss? YouTube, right? We've got all of those. We go live 3 times a week with webinars just like this. So you can always stream them for free. You can sign up for a lot of the webinars for free on our website as well. So you can scan that code to get over to our webinars page and you can see which ones are free, which ones are paid. You can also join us on social media for cheat sheets and tips, and all of those good things come for free because we're going to answer you on social media. And then our YouTube channel has a wealth of videos. We also have a podcast that is totally free. It is called Pulse Check with Archer Nursing. I will go ahead and type that into the comments here. Pulse Check with Archer Nursing. I am the host of that podcast. I host a 15-minute quick episode every Tuesday and Thursday. So you can go and get a good rundown of all sorts of different topics. Today I just recorded one on Cushing's disease. So you will get walked through kind of like the topic, a case study of like a patient that I saw when I was working at the bedside. And all of that jazz. So Pulse Check with Archer Nursing is available on Spotify, Apple Podcasts, YouTube, like all the things, and is totally free. So that is that. Okay, so hopefully that helped, Michelle. That gives you a few resources that you do not have to subscribe to. There we go. Navant, I need to watch pre-recorded sure past videos. Is that possible? Absolutely. Let me put the code up for you so that you have that. We are going to go right over here. Hopefully everyone who needed to get into that webinar got it. And this will give you the access to our Sure Pass program here. So RN, sign up here. PN, sign up here. Our Sure Pass program is going to include the Q Bank that has unlimited readiness assessments and CAT exams, all of the on-demand videos that you were just talking about, Navach. We have those on-demand videos ready. It also includes a 3-day live review and daily live lectures. So you can come and ask us questions as much as you need, Monday through Friday. We're here, we're joining live with you. You ask us any questions that you have. So again, sign up here for RN, here for PN. And I do have a code for any of you joining that don't already have an Archer account. I love Archer, all one words, all caps. And you can go ahead and get 10% off. That is only for you guys who join our webinars. So feel free to use that code if you need the SurePass program. So does the SurePass offer a tailored study guide, or does it have to be paid separately? Yes, the SurePass program comes with 3, 4, 6, 9, and 12-week study guides that we have crafted based on best practice and different time constraints. So for example, if you work 3 days a week, you probably want to do like the 6-week study guide that only has 4 days a week of studying so that you can kind of balance, like you don't have to study when you're at work, you know? You have many different options, so you can pick those. If those don't work for you and you want to personally work one-on-one with somebody to craft an individual schedule, you can sign up for one of our 30-minute private tutoring sessions, and we will do an individualized study plan for you. I was trying to subscribe for SurePass, but could not find it. Okay, so hopefully this code will get you where you need to go, Michelle. RN SurePass right here and PN right here. You can also just head over to archerreview.com and you'll click on nursing up at the top, and then you'll see all of those choices. Are there reviews for advanced med-surg? Yes, we have a wonderful nursing school companion product, and that has both med-surg 1 and med-surg 2, which is our critical care nursing. Different schools call them different things, but that med-surg 2 critical care nursing is typically like the advanced, like the last class that you take in your BSN program. And that is going to be a question bank and on-demand videos that guide you through the entire med-surg course. You can get the individual course for $15. If you're just starting out nursing school, we have 20 courses that go through every single course you will take in nursing school, and you can get that full bundle for $199. So go to archerreview.com, click on nursing school, and you will see all of those things, med-surg and everything. Yes, critical care. Excellent. So, Benjamin, let me know if you cannot find that on the website. I am happy to send you the direct link. Let me just go ahead and put it actually in the link for everybody, or in the chat. Here we go. There we go. Sending that to everybody. The nursing school product was like such a labor of love with all of the different things we put into it. I taught the pediatrics course and the growth and development course. All of those sorts of things are my area of expertise. For example, our geriatrics course was taught by Dr. Annalise Heaps, who is a gerontology family nurse practitioner. We have our obstetrics course taught by Dr. Bonner, who is a certified nurse midwife. Everybody just really an expert in their field that loves their field, teaching those specific courses. It's really, really fun. I know I wish we had come out with it sooner, but share it with your friends starting nursing school, and go ahead and share that code with them. I love Archer, all one words, all caps. That's going to get them 10% off. And really, each course is just $15. Like, we want it to be very accessible to you guys. I love it. I love it. I just signed up for SurePass. Are the webinars recorded? Yes, Rosebert, the webinars are actually recorded, so you are going to be able to see those as part of your SurePass program. Absolutely. Are the normal ranges written on the real NCLEX exam? Yes, our next generation NCLEX included an update where they include the real ranges, or the normal ranges. So you'll know what's within normal limit. It's less about memorizing numbers and more about understanding what they actually mean. So yeah, that's really good. Great. Cindy just signed up for the 3-day Sure Pass. So that is really, really wonderful. That is a nice high impact 3-day live review that comes with that. And we cannot wait to have you. All right. I think I have gotten through most of the questions, but just in case I have managed to miss something, I'm trying to watch a few different places. So if I have missed something, I'm just going to go ahead and drop our email address in the chats right now. It is support@archerreview.com. Please feel free to email us any question at any time. We'll get back to you within 48 hours so that we can make sure we follow up with you on your specific question and anything that you need. All right. With that being said, everyone, go have a great rest of your evening. I will be back with you on July 14th here in 2 weeks so that we can go even further into congenital heart defects and really demystify it together. I hope to see you there. I'll leave this up for another minute, but otherwise, have an amazing night. Remember, this is not easy, but it is worth it. You guys have got this. Archer is with you every step of the way. Bye.